We're going to go ahead and get started.
Okay.
I'm Judy Noodleman, a member of the Wellness Committee. Just FYI, our next wellness lecture is April 15th with Karen Ashworth, who's an estate attorney, on the topic of legal options for a smooth estate. Please silence or turn off your cell phones. And actually, Leila would like your questions and interaction during the session, so we'll float the microphone through the room. It's my pleasure to welcome Dr. Leila Saadatpour to help educate us on movement disorders and challenges in their diagnosis. Leila, a movement disorder specialist, earned her MD from Isfahan University of Medical Sciences in Iran. In 2015, she came to the U.S. and joined McKnight Brain Institute of University of Florida as a research fellow in behavioral neurology, and then as a postdoctoral researcher focused on dopamine transmission and neurodegenerative diseases. In 2018, she came to UT Health San Antonio for her residency in neurology. In 2022, after completing her residency, Leila joined the Cleveland Clinic as a movement disorders fellow, and in 2024 returned to San Antonio as assistant professor at UT Health San Antonio. UT Health San Antonio is a Michael J. Fox Center of Excellence, and in 2024 was the second location in Texas to be designated as a Cure PSP Center of Care. Leila directs the Cure PSP Center of Care. For 8 years, I've led the Central Texas Cure PSP support group for atypical Parkinsonisms, and you'll hear about each of them from Leila. During these 8 years, I've often heard from the people involved about years of misdiagnosis. For 6 years, I was the caregiver for my husband, Harvey, who was impacted by the atypical Parkinsonism disease, progressive supranuclear palsy, PSP. When you get these diagnoses, you usually haven't ever heard of them, which I did not. I deeply appreciate Dr. Saadatpour's work. It's been my pleasure to interact with her since San Antonio was designated a Cure PSP Center of Care. Please join me in welcoming Dr. Saadatpour to Westminster.
Thank you so much, Judy. Do you guys hear me okay? Is that loud enough? Okay. I'm so glad to be here, and Judy, I really appreciate you inviting me here to our neighbor city, Austin. I just live down the road in San Antonio, and it was a quick and nice drive for me. For those of you watching me who watched me eating just a moment ago, it's because I have a 1-year-old and I really don't get time to eat at home when I go, so I have to find any minute in between so I can take a bite. So I'm really glad to be here. It's really, really nice getting to know and meeting you, everybody. My slides are really short and very brief, so I would like this session to be really interactive rather than just me as a solo speaker and people just dozing off. In the meantime, it's 7 p.m., so there can be some people's sleep time, including myself. So feel free to interrupt me, feel free to jump in. Judy's holding the floating microphone over there, so whoever wants to speak out, just raise your hand. I'll stop and you guys can take over and we'll make it very interactive. These slides are probably going to last for 15 to 20 minutes. So the rest of this session is just going to be Q&A in case anybody has any questions about these kinds of disorders that I'm going to talk about. So I am a movement disorder specialist, and majority of my practice focuses on Parkinsonian disorders, including Parkinson's disease and atypical Parkinsonian disorders, and that's what we're gonna have some education on tonight. And I just realized this font is too small, so I'm so sorry. It's like super hard to read it here. It's like when AI becomes unhelpful, I let it edited for me, and that didn't turn out too great here. It was looking different on my own MacBook. So Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's. Parkinson's happens because of dopamine deficit. What is dopamine? Dopamine is a hormone. Everybody has dopamine. It's being produced in the basal ganglia, the deeper parts of the brain. And as we get older, the neurons don't grow back. They just keep degenerating over years and years. So if you lose a certain portion of the neurons that are producing dopamine, the reduction in dopamine production is what is going to cause Parkinsonism or Parkinsonian disorders. Everybody knows about Parkinson's disease. That's the most famous one. But we're going to talk about how Parkinsonism and Parkinson's disease are going to be different, in case some of you might have heard of that, or your loved ones are diagnosed with this. And in some cases, they're diagnosed with Parkinsonism. Some are called Parkinson's disease, and that those two terms can be really confusing to tease apart. Parkinson's disease, or Parkinsonian signs in general, are divided into 3 or 4 main categories. The first one is what we call bradykinesia, or slowness of movement. So when you're moving, things get a little slower. The way we test it in the office is that we ask for tapping fingers, opening, closing cans, and then as physicians, we're going to look into the speed that you're doing that, and we're going to judge if that's a slower speed or a normal one. And if it is slow, or it gets slower as you're doing it, we call it bradykinesia. That's the slowness of movement. The second side in Parkinson's is rigidity. Rigidity is stiffness of muscles. So the range of motion of muscles are stiffer. The third sign is a tremor. So in Parkinsonian disorder, the tremor is a resting tremor. So a resting tremor is different from an action tremor. The action tremor is if you're holding out, reaching to something, you might shake a little bit. That's not usually a Parkinsonian tremor. It's an action tremor. The resting tremor on the other side, which is characteristic of Parkinson's disease, is that if you're not doing anything, just watching movies, and then your hand would go like that, and as soon as you pay attention to the tremor, it actually can go away. That's a resting tremor, and that's very characteristic of Parkinsonian tremor. And then at the end, there is gait and balance problems. So certain characteristics when you walk, if the stride is shorter, if you're not lifting up the legs enough, the feet enough, the speed is slower, posture gets a little stooped. Those are signs of Parkinsonian signs in general, and it could be Parkinson's disease or one of the other Parkinsonian disorders. So what is Parkinsonism? So you guys should think of Parkinsonism as the main umbrella. So it's a constellation, it's a symptom complex, the symptoms that we just talked about. Slowness of movements, rigidity of muscles, balance problems, maybe resting tremor. If there's some of those symptoms or those signs, but we don't quite know what is going on, we call it Parkinsonism. That's signs of Parkinson's. But we don't know if it's Parkinson's disease or it's one of the atypical Parkinsonian disorders. So with the atypical Parkinsonian disorders, there's usually some red flags that we can pick up from the get-go and in the process of the disease, and that can differentiate Parkinson's disease from the atypical disorders. Let's see if I covered everything there. Of course, Parkinson's disease is more common and atypical disorders are less common. So by atypical Parkinsonian disorders, they used to be called Parkinson's plus group. They're no longer called that way, but some older school doctors may still call them Parkinson's plus. And by them, there are 4 main categories: progressive supranuclear palsy, or PSP, multiple system atrophy, or MSA, DLB, which is dementia with Lewy bodies, and CBD, which is corticobasal degeneration. Also corticobasal syndrome is the same thing. So how are these two different? How can we tease Parkinson's disease apart from atypical Parkinsonian disorders? Parkinson's disease almost always starts asymmetrically. It always involves one side more than the other side. It's right or left. During the progression of the disease in years and years, it can go to the other side of the body, but that other side is never going to go as bad as the first side that started out tremoring or getting slower or getting stiffer, basically any of those other signs that we talked about. So it's asymmetric, it's gradual, and it's slow. So changes in Parkinson's disease are mainly noted within years interval. So during 1 year, you don't notice a whole lot. You may have a little bit of a tremor, which can get just a touch more at the end of the year. But you can really notice the changes within 3 years, 5 years, 10 years interval. That's how slow Parkinson's disease is. And it responds to the medication. The medication, the gold standard, oldest, and still the best medicine for Parkinson's is levodopa-carbidopa. Levodopa is actually the main dopamine component of it. And Parkinson's disease responds pretty well to levodopa. So one way actually to differentiate if this is Parkinson's disease or one of the atypical disorders is to start the medicine and see how the patients respond to the medicine. If the symptoms go away or get a lot better with the medicine, that's a sign that this is Parkinson's disease. And main concern in Parkinson's disease is usually motoric concerns, tremor, slowness, stiffness. Well, Parkinson's disease and Parkinsonia disorders can have non-motor signs. So it's not only motor. There could be non-motor signs. There can be anxiety, depression, loss of sense of smell, acting out dreams at night, constipation. Those are all very common signs that are non-motor in Parkinson's disease. But still, with Parkinson's disease itself, the main problem is going to be motor problems. That's the most problem, especially starting out having the disease. After 5 to 10 years, the non-motor signs can be a little bit more overwhelming. On the other side, if the disease is progressing too fast, if someone gets wheelchair bound within a year, if they keep falling a lot within a year, if they fall a lot backwards, if they keep passing out during the year. So those are all alerting signs that this is not Parkinson's disease because it's been very faster progressive. In terms of their progression, it's a lot more faster. A lot of times there is early on other non-motor signs that we're going to talk about in the next slides, which is different in each of the atypical disorders, but there's a lot of balance issues. There could be blood pressure fluctuations, and all of those non-motor signs that are really jumping out from the starting of the disease. And of course, in terms of the cognitive slowing and progression, in certain atypical disorders, it's a lot faster than Parkinson's. Well, dementia and cognitive slowing can happen in any Parkinsonian disorder. But in Parkinson's disease, there is usually no dementia within the first 5 years, and absolutely no dementia in the first year. So there could be, case by case, everybody is very different. How disease progresses is very different case by case, so we cannot call all of them under one, category. But generally speaking, in Parkinson's disease, there's no dementia in the first year. Some slowness in cognitive processing can happen after a year, but it's usually 5 years or longer when dementia becomes more pronounced. Versus in certain atypical disorders, dementia can happen from the get-go in the start of the disease. Any questions so far? We're good? Everybody knows about the two? Okay. So we're going to talk about more now. Okay, so key features of each of these atypical Parkinsonian disorders. So PSP, or progressive supranuclear palsy, it comes with two main signs. One is double vision. That's because of difficulty voluntarily moving eyes from one side to the other, mainly from up or down. There is difficulty moving eyes up or down, so patients need to move their head if they want to look up and down, because the eyes wouldn't move up and down. So that's one of the most prominent signs of PSP. and falling backwards. So postural instability. If someone keeps falling backwards earlier in the course of the disease, that's an alerting sign that this might be PSP or progressive supranuclear palsy. MSA, multiple system atrophy, there's a lot of autonomic dysfunction. What is autonomic dysfunction? Autonomic nervous system is a nervous system in the body that controls little things, like controlling blood pressure management in the body, sweating, urinary, holding your urine, like if someone can voluntarily hold the urine, or if the autonomic system is destroyed, then you're going to have urinary incontinence. So all of those little things, controlling sphincters, bladder function, sweating function, blood pressure function, sexual functioning, is under autonomic nervous system. And in MSA, there's degeneration in autonomic nervous system. So their main first signs are going to be autonomic dysfunction, bladder incontinence, bowel incontinence, cold feet or hand, purple fingers because they don't have enough perfusion, enough blood flow in the fingers. Blood pressure fluctuations. So one of the most concerning finding is that when someone with MSA stands up, the blood pressure cannot push up and it drops. So they can pass out or they can fall when they're standing because of the drop in the blood pressure, which is called orthostatic hypotension in medicine. So those are signs of MSA. The other sign in MSA is cerebellar dysfunction. The cerebellum is in the back of the brain and it controls balance and coordination. When that's degenerated or impaired, then there's going to be loss of balance and loss of coordination. So that's also one of the main signs in MSA. Dementia with Lewy bodies, or DLB, is a twin brother of Parkinson's disease. So amongst all of this, dementia with Lewy body is the most similar to Parkinson's disease because the pathology underlying both of those disorders is Lewy body disease. It's something that accumulates inside the neurons called the Lewy bodies, and that's exactly the same thing in Lewy body, dementia with Lewy bodies, and Parkinson's disease. So if you cut the brain open after autopsy, you can't really tell if this was dementia with Lewy bodies or Parkinson's disease because the pathology is exactly the same thing. However, the symptoms are different. So in dementia with Lewy bodies, you have early dementia. So the memory dysfunction happens before the motor dysfunction. So they get the memory problems, dementia first, hallucinations are very common, and then they get tremors or balance problems afterwards. And that's how we actually differentiate the two. One very specific characterization with memory dysfunction in dementia with Lewy bodies is fluctuations, cognitive fluctuations. So through one day, there could be really lucid periods and very staring off, dozing off periods. So it's like fluctuating cognition is one of the main characteristics in dementia with Lewy bodies. Hallucinations, fluctuations, dementia, memory problems, plus Parkinsonian signs, slowness, stiffness, tremor, all of that. And then last but not least is corticobasal degeneration, which is also asymmetric. Like in Parkinson's, it starts out in one side, but it's a lot more faster in terms of progression. A lot of people get stiff posture in one side, so their hands would look like that, and that curls up and curls up, or the leg would do the same thing. They have difficulty using that limb. They have difficulty picking on objects. They can't brush their teeth if that's their dominant hand anymore. And there's, of course, other cognitive problems that show up earlier in the course of the disease with corticobasal degeneration. Lots of times corticobasal degeneration and Alzheimer's can actually look similar. So how do we as doctors differentiate these from each other? So it's not only the neurological exam, well, of course that's the most important one, the history of progression. The neurological exam is the main thing. But we have all of these other fancier tools that we can differentiate. We can do a brain MRI, and in some cases there's certain characteristics that can point toward one disease or the other one. Nowadays, there's skin or spinal fluid sampling. So skin biopsy, which is going to look for synuclein. That's the protein that it goes in a weird shape in Parkinson's disease, multiple systems atrophy, and dementia with Lewy bodies. So if we are debating whether this is Parkinson's disease or PSP, for example, doing a skin biopsy or a tap for the lumbar spine fluid, that's going to help out for that synuclein protein. And then the DAT scan is a type of scan that looks for dopamine uptake in the brain, and it's going to be an abnormal in all of the above disorders, because all of these disorders that we talked about, they all have the dopamine deficiency. Questions? Anyone? Nope? Yes, sir. Go ahead.
Testing.
Are muscle vacillations, particularly, of course, you can notice them in your limbs, related to this? I mean, you mentioned the hand movements and that kind of thing, and I mean, often I can look at my forearm or look at my leg, and they're walking. I mean, they're very active without me being present.
Yeah.
Where does that fit in? And if it's totally somewhere else, just say so.
Yeah, it's actually a tough question, because a neurologist has to actually observe it and see what kind of muscle movement is it. If it's just like a rippling movement, what we call in neurology fasciculations, if it's just like this, like a rippling movement, that's not related to any of these conditions. It can be related to ALS, which is a totally different disease. It's a motor neuron disease, and it falls into neuromuscular subspecialty, got me. So they can get a lot of muscular fasciculation, plus a bunch of other signs. So speaking of fasciculation, I'm thinking about ALS and motor neuron disease first. But if this is a muscle jerk, which is like this, and it's unilateral, and then there's some muscle posturing, and then the jerks happen on top of the posture, that's corticobasal degeneration that can happen in that. However, muscle jerks are very non-specific, and they can happen in a whole bunch of other conditions. It can be medication-induced. So usually when we get older, we get on a bunch of medications, and these medications can give you fasciculations, can give you tremor, can give you. So the first thing that the neurologist does has to rule out if this is something that's medication-induced. So, yes, ma'am.
Is there anything known about the genetics?
Yes. So genetics play a role specifically in Parkinson's disease. It is important. So Parkinson's disease can be genetic in 10 to 15% of times. So 85% it is not genetic. 10 to 15% it can be genetic, and there are 7 common genes that we check for if there is family history of Parkinson's. With atypical disorders, it's a little harder to talk about genetics because there is not a certain gene that we know causes it. However, there are genes for Alzheimer's, and Alzheimer's and corticobasal syndrome can overlap a lot. So if there's family history of Alzheimer's and your patient has corticobasal, maybe checking those genes would be beneficial. There are no genes for PSP or MSA that I know of. Anyone else? Okay, I'll move on. So treatment and management. So with Parkinson's disease, we already said that levodopa carbidopa is the main key treatment. We usually start out with that. There are a bunch of other dopaminergic treatments that we can try if levodopa didn't work out for any reason. There's deep brain stimulation surgery for Parkinson's disease. So Parkinson's disease has all of its own fancy treatments, and it's usually pretty well responsive to all of the above treatments. However, the atypical disorders, we start out with levodopa and see how they handle it, but it's usually not as well responsive. So it's a faster progressive disorder. Unfortunately, it's not going to respond as well to the dopaminergic replacement, and there's no surgical treatment that can be helpful yet for atypical disorders. However, staying active, doing physical exercise, physical therapy, speech, occupational therapy is the main treatment for atypical disorders. It's also very important in Parkinson's disease, but again, because Parkinson's is more responsive to medicines, PT, speech, and occupational therapy becomes more the whole key treatment for atypical disorders. So we have to have all of the above services included whenever we see a patient with any of those atypical disorders. So again, physical exercise, doing yoga, walking, stationary bike helps with Parkinson's disease. It's actually the only intervention that slows Parkinson's down. They did a research on a group of patients who were doing physical exercise, aerobic exercises, and the group that were not doing it, and the group that were doing the physical exercise, they did a lot better in their motor scoring after a few years compared to the group that was not doing it. So it's actually really, really important. It's the only disease-modifying intervention we have for Parkinson's disease, so staying active is really, really important. It's important in atypical disorders as well, but we understand that the balance issues or blood pressure fluctuations can be a barrier in terms of how intense they can exercise. Diet, it's important. So in Parkinson's disease, Mediterranean diet is usually recommended, generally speaking, because it's a healthier kind of diet. So we recommend against eating, fatty, unhealthy food, and we would like Parkinsonian patients to have a combo of everything. That's why we call it Mediterranean, because it has a little bit of, veggie, meat, carb, kind of everything. And do not feel shy to seek support, because it's unbelievable, even with atypical disorders, how much we can actually do. A lot of times there's other services that we can give, or if there is a spastic limb, if there is muscle overactivation, we can treat it with botulinum toxin injections, or all of these other things that it's always good to see a specialist, because there could be all of those little things that can actually improve after you see a neurologist or a specialist. Despite that we know that there is no treatment or a cure for these disorders, there's still a lot to do, because there are all of those signs that we can still take good care of. Drooling, for example, is a very common finding in all of the Parkinsonian disorders, and there's a simple treatment for drooling. It's just Botox injection, and that works pretty well. So all of these symptoms affect life quality, so it's always good to seek support. And to stay informed, be on top of research. The clinicaltrials.gov website, the QPSP website, they always update the active research going on in all of these disorders. Michael J. Fox Foundation, Parkinson's Foundation for Parkinson's disease. So it's good to be on board and see if there's anything coming up. Anybody likes to volunteer, there's always opportunities for research. So I'm going to just speak a little bit about our center in San Antonio. So we just moved to the Center for Brain Health. It's a neurology dedicated building for neurology offices, clinics, and multidisciplinary clinics, including physical, occupational therapy, speech therapy, social work, and genetic counseling. So we do have that opportunity if someone is traveling from farther away, like Austin to San Antonio, we can offer you a multidisciplinary clinic appointment where you can see everybody in one day. And we just became QPSP Center of Care last year, and as part of that designation, we have certain funding that we can dedicate to atypical Parkinsonian disorders. We can help, our social worker is amazing, and she can actually help out with so many social needs and aids that patients might need at home. Here is our team at UT Health San Antonio. So currently we have 4 movement disorder specialists. We're hiring 1 in summer, who's going to join us as the 5th member. We have 3 advanced practice providers, research coordinators, we have a clinic coordinator, social work, and genetic counseling. And we have an upcoming symposium on atypical Parkinsonian disorder, which is going to be extremely educational and short. Judy is going to be there with us on that day. It's May 15. If anyone wants to know more about atypical disorder or has atypical disorders or has a loved person with atypical disorders, you're welcome to join. We have flyers with the QR codes that you can scan and go in, so you don't need to write that website down. And we're going to talk about the clinical care, support and therapy services, research updates, and of course, Judy's there too. So there's always hope. There's always research, which is going to end up some, brightness at the end of the line. For all of the above disorders, Michael J. Fox is doing a lot for Parkinson's disease, Cure PSP for atypical disorders. Again, active clinical trials are going up. There's hope down the road for genetic variants of Parkinson's. We're very close to coming up with some cure for certain variants. So a lot of excitement in this field. So it's actually having a really good future, especially for Parkinson's disease. It's a little harder for atypical Parkinsonian disorders because they're faster and they're more rare to find. So it's a little harder to have that good number of group of patients to study on. But again, there are some research going on for those disorders as well. Specialized care really works. We try to treat you individually. We hear your concerns and we target your concerns. So even if you're joining support group meetings and you're going to meet with a bunch of other patients and you're going to see the whole spectrum of how this disorder may look like, do not ever compare yourself to another person or fellow with this disorder, because again, your body is your body and it's very special and it treats you differently, and Parkinson's can look very different case by case. Atypical disorder is the same thing. So you have to have your own specialized, individualized care by your neurologist. And you're not alone in this. So we're here to support you. There are wonderful people like Judy who hold support group sessions, and they can have people come together and help each other and come up with some sort of a plan if someone is struggling with an aid or finding doctors or anything in that category. Reach out for help, and we're here to help you. You can always reach out to me. I can share my email with you guys, and if at any time you wanted to have an appointment with us or questions or anything, we'd be happy to help you out. And that's all I have for tonight.
Questions? By the way, the flyers for the May session are here if anybody's interested. And they're
Question down there. And one here.
If Parkinson's is in your background, my mother had it, is L-DOPA preventive, or is it only after you have it?
It's only after you have it. It's not preventive. At this time, we don't have any medicines that can prevent Parkinson's. L-DOPA only helps with dopamine replacement. So if your dopamine level is low enough that you would need replacement for it, it's going to help us. It's not going to prevent, it's just symptom management. Exercise does, though. Exercise protects you.
I'm already beginning to fall, like fell and fallen a couple of times.
So falling can...
They told me to start wearing shoes.
Falling can be a sign, but it's, again, it has to be evaluated by a neurologist to have its own certain way, because there are so many reasons for falls. We can have bad back, we can have a bad knee, or, orthopedic limitations, or all of that can make you fall. So it's not only Parkinson's disease. Again, it has to be a few signs of those that we discussed: the stiffness, slowness, gait problems, tremor, and if there's certain numbers of those, then you fall in within the category of Parkinson's. The non-motor signs are important too: loss of sense of smell, acted out dreams at night, constipation.
I have a question.
Yes.
Yesterday I read an article, a very, very brief article, with the Japanese
experimenting with stem
Stem
cells.
cells, yeah.
Do you know anything about that?
It's very exciting. I read that too. So it's getting somewhere finally. Stem cells have been in research for Parkinson's disease since 1980s or 70s. So it's long enough for us to finally have a way to do it. Because there are so many different ways to replace stem cells in the brain. So for those who don't know, stem cells, so like I said, you cannot replace the neurons that produce dopamine because they degenerate as we get older and there's no way to regrow them. But there's stem cell therapy. So the stem cells have to go in a specific way that they go and replace those exact neurons without causing extra trouble. And that's what has been going on since 1980s, but yet they've been there to find, a certain way of actually doing it without causing trouble. Because a lot of times when you transplant stem cells from another human being to another one, then you have to suppress the immune system to not act out, and there are all of these other problems that can happen. Plus that this should be a surgery because it has to go inside the brain to replace, and so it has its own risks of that. But there is this Japanese stem cell way of doing that's finally getting somewhere. So I'm excited about that too, to see if it's gonna, how the results are gonna show in real life. And currently in the States, we don't have an FDA-approved stem cell therapy for Parkinson's. There are clinics around the country and in the Caribbean that offer doing stem cell therapy for a lot of money, $20,000, $30,000. They're all scam, so don't go to those clinics. Because again, there is no FDA-approved way of doing stem cell therapy here in the States. The Japanese one may get somewhere. So we're going to look for that if something similar is going to come to the States. So we know that we have a safe way and effective way of stem cell transplant.
I have a question. How do you distinguish between somebody with Parkinson's disease having mild cognitive impairment and that progressing into Parkinson's dementia versus Lewy body dementia?
Very good question and a challenge of movement disorder specialist. And again, there is not a fine line. There is not a fine line because the pathology is the same thing. So if the rule of thumb is that if the motor signs appear at least a year before cognitive impairment, we call it Parkinson's disease. Even if it's going to go to dementia at some point, we call it Parkinson's disease dementia. If the dementia comes before or within the same year of motor symptoms, we call it Lewy body dementia. So it's very evaluators dependent of how they want to call it.
Leila, I have a question for you. So Harvey had PSP, and the brain autopsy showed he also had Alzheimer's.
Mm-hmm.
So are we doing a better job now to be able to distinguish that those two things are happening?
Yeah, so co-pathology, we call it co-pathology when there's two pathologies happening at the same time, corticobasal and Alzheimer's, PSP and Alzheimer's, Parkinson's and Alzheimer's. They can happen together. So it's just unfortunate if someone has both. And a lot of times it's harder because we tend to focus on the main prominent signs and we forget about all these additional signs as providers. But there could be signs of Alzheimer's along with the motor signs that he had that they just didn't pay attention to. However, there's still no treatment for any of them. Well, I know there are some Alzheimer's treatments, but they're still not as good to be called disease modifying in my opinion. So yeah, co-pathology is a challenge for doctors.
You mentioned that there are some potential drug treatments for people with specific genetic mutations.
Yes.
Which mutations seem to be coming forth first?
Yes, so GBA and LRRK2, LRRK2, they're the two commonest, the most common genetic variants of Parkinson's. There have been trials for gene therapy trials to actually remove the gene, like, for cancer, a lot of cancer treatments we have gene therapy, so we actually cure the cancer. So they're gonna do the same technique for these two specific because they're just more common. So in their research, they could have had more numbers to accomplish what they wanted to. So GBA is very close to have certain variants of it. They still have more variants within GBA. So GBA and LARC2, those two.
Are there variants in LARC2?
There are variants in LARC2 too, as well. I'm not aware of the trials being different in different variants. I'm aware of the GBA variants. For LARC2, I think it's all under LARC2. As far as my understanding goes, I could be wrong though.
And LARC2 is on chromosome 12, and you get it from either parent, correct?
I believe so. My genetic knowledge is not the best. Yeah, but I believe so. Yeah. LARC2 is a variant in Parkinson's that can be synuclein negative. So it's an interesting one.
It can be what?
Synuclein negative. So the protein I talked about that can be found under the skin and in the lumbar fluid, it can be negative. It can not even be present in LARC2 variants. So there is another way of getting Parkinson's, not by the synuclein pathology in LARC2.
We know that cumulative brain damage is associated with Alzheimer's disease. Do we know if it's related to Parkinson's or not?
What was your accumulated? What do you mean?
Boxers, football players.
Oh, okay.
People who've been in the
Yep,
service.
Of course, it is definitely traumatic brain injury. It is
both.
for both, for Parkinson's as well. Muhammad Ali had Parkinson's from that.
Oh.
Yeah, traumatic brain injury is always a risk factor for all of the above. Yes,
I
ma'am?
understand there are geographic areas that have more Parkinson's, and they're researching those particular areas.
Have they come up with any suggestions about what might be the cause of the environmental cause?
Yeah, so it's a good question. The Valley of Texas is a hot area in Parkinson's. A lot of it is because of pesticides. So there are certain types of pesticides and toxins. So people live by golf courses or farms where there's a lot of pesticide use tend to get Parkinson's more often. And that's definitely a risk factor. In the military bases, there's a lot of toxin exposure. The Agent Orange, probably all of you know about that one, which was a direct cause of Parkinson's in the veterans. So it's mainly the environmental toxins are pesticides, and occasionally it's like some sort of toxin used in dry cleaning. So people who were in this industry tend to get Parkinson's more. There's all these like little researches on air pollution or other types of toxin, but they haven't gone anywhere. So we still don't know if air pollution is connected to Parkinson's, but we for sure know that pesticides do.
Any other questions? Well, thank you so much, Leila.
Thank you.
This was really enlightening.
Thank you.